On this punch biopsy, you can notice widening of the septa in between the adipocyte or the fat lobules. So this would classify as a septal paniculitis. So you see that above that subcutaneous tissue, the rest of the specimen, the epidermis and the dermis, looks fairly unremarkable. Not a lot of pathologic change here. As you go down here, you see the widening of the septa with mixed inflammation, but mostly lymphocytes, histiocytes, and these really nice giant cells here, or Meissner's granulomas. So that's a characteristic of erythema nodosum. You won't always have it, and just depending on how inflamed the particular lesion is, but for the classics that you should be tested on, you're going to have a nice widening of the septa with mixed inflammation containing abundant giant cells, lymphocytes, histiocytes. And this is pretty much picture perfect for erythema nodosum. Now, how can you tell it's a septal paniculitis and not a lobular? Sometimes that can be confusing for beginners. So you see that the areas in between these distinct aggregates or islands of adipocytes, that's where all the inflammation is in the septa. But if you go into the lobule, most of the cell wall in between the individual adipocytes is not filled up with inflammation. And so it's not a lobular paniculitis, it's a septal paniculitis. Now, in reality, you do get some spillover into the periphery of the lobule. So if you just looked at this, you might think it's lobular, but it's you got to look at it holistically, right? So most of the adipocytes have very clean wall-to-wall placement without significant amounts of inflammation. So this is a septal paniculitis, and your most key example of a septal paniculitis is erythema nodosum. So just wanted to show you a really good textbook example of erythema nodosum.